Welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. Today's episode is on considering rapid ART in a patient with opioid use disorder, featuring Dr. Jason Halperin from CrescentCare in New Orleans, Louisiana. He'll take us through a case study of a patient presenting with both HIV and opioid use disorder, and he'll explore the data to support his decision to rapidly initiate ART and provide treatment for opioid use disorder at the same time. This episode is taken from our series on key decisions in HIV care. You can follow along with the slides, which are available in the show notes. Let's get started and listen in to Dr. Halperin.
Welcome to Key Decisions in HIV. I'm excited to present a case considering rapid ART in a patient with opiate use disorder. My name is Jason Halperin. I'm an assistant professor of medicine at Tulane University and the infectious disease clinical lead at CrescentCare, a federally qualified health center in New Orleans. Well, let's jump in with a case. An adult patient who is newly diagnosed with HIV is establishing care. He is currently using IV heroin daily. He started opiates after a molar extraction, and then he began buying prescription opiates from the street, and he is now using heroin. His past medical history is significant for reported hepatitis C virus that has been untreated. His physical exam is benign and negative for any signs of cirrhosis. So we have this newly diagnosed patient. What are the recommendations for starting ART? Well, both the DHHS guidelines and the IAS-USA guidelines endorse the use of rapid ART, meaning to start antiretroviral therapy as soon as possible after diagnosis, ideally same day if possible. So DHHS states initiate ART immediately after HIV diagnosis to increase the uptake of ART and linkage to care, decrease the time to viral suppression for individual patients, and improve the rate of virologic suppression among persons with HIV. And IAS-USA endorses the same. So what are the key DAH guidelines or recommendations for substance use disorder and HIV? Well, ongoing substance use is not a contraindication to ART. People with HIV and substance use disorder should be offered evidence-based pharmacotherapy for their substance use disorder as part of a comprehensive HIV care in clinical settings. And ARV regimens that are once daily are preferred because the high barrier of resistance, low hepatotoxicity, and low potential for drug-drug interactions. We also have SAMSHA guidelines that look specifically at opiate use disorder, a component of substance use disorder, much like the case that we're describing today. And opiate use disorder medications can help patients reduce or stop illicit opiate use and improve their health and functioning. Medication should be considered for all patients with opiate use disorder. That conversation is essential within the clinic. Patients with OUD should be informed of the risk and benefits of medications to treat OUD, and the treatment without medication and no treatment should all be discussed as an essential part of that clinic visit. So we do have multiple treatments for OUD, and these are the three that you will see in the HIV clinic setting. Methadone, which isn't mentioned here, is also a medication that can be used, but is typically not available within the HIV clinic setting. So let's start with naloxone, also known as Narcan. This is an intranasal or intramuscular or subcutaneous or intravenous injection. It's used as needed for overdose prevention. There's no special training or licensing to prescribe at all. There's actually some great YouTube videos that a prescriber can show their patient so that a patient can feel confident knowing that they're leaving the clinic with a life-saving medication that can prevent overdose. It is my recommendation in my clinic that every single person that comes in who is struggling with opiate use disorder leave with Narcan. It is something that they should have within their homes, and they should make anyone that they're living with or using with aware that that medication is available. Let's now talk about some maintenance medication. Well, buprenorphine is one, something that can be prescribed within your clinic setting. It comes sublingual as a film or tablet, as an implant or injection. And then, of course, the frequency is dependent on the delivery method. Now, in terms of prescribing, there's some changes here. Those prescribers who want to treat up to 30 patients do not need any extra training. But if you are going to treat, like myself, some more than 30 patients within your clinic, the MD training is 8 hours and the PA and NP training is 24 hours. I will say I really recommend the training. I don't know if it's necessary for an X license. That is something that politically we should probably advocate is not necessary. But the training itself was very, very helpful. And in that 8 hour training, I felt much more confident in my prescribing. There's also extended release naltrexone, which comes in an injection form. It can be prescribed monthly, and there's no special training or licensing. These are medications that are all life-saving and can be prescribed within the clinic setting. And here you could see there are few drug-drug interactions between opiate use disorder treatment medications and the rapid ART options. You could see the recommended rapid ART treatment options on the left, and you could see no interaction expected with the exception of using darunavir plus ritonavir for naloxone or buprenorphine. And I have to say that interaction is potential, often can be explained to patient and then proceeded with prescribing. Darunavir with cobicistat, there is that potential weak interaction that must be followed with buprenorphine. But you can see that overall, most of the medications we use for rapid ART, there is no concern for drug-drug interactions. So medication treatment for opiate use disorder improves HIV viral suppression rates. So before we even get there, it saves lives. So it is life-saving in terms of the opiate use. But here you can also see when incorporated within an HIV clinic, you're going to have an increase, a 69% increase out of this meta-analysis that looked at 32 studies in ART uptake, a twofold increase in ART adherence, and a 45% increase in viral suppression. Really, really impressive data on the importance of incorporating OUD treatment within your HIV clinic. So I have been seeing a patient, one of my first within our Rapid Start program for now almost 5 years. He is going to speak momentarily, but one thing that he speaks about is that he lives outside of New Orleans. It takes him hours on public transportation to come to our clinic. If he had to see multiple providers, I really know it would be difficult for him to have to prioritize. Does he see the prescriber of Suboxone or his HIV provider? But the fact that I'm able to do both for him has been essential in him achieving viral suppression and maintaining his stability on buprenorphine. So here he is now.
Why has it been so important for me to be able to get it all at one spot? Is because sometimes, you have to catch the buses. I don't have a vehicle, I got to catch the buses. And I'm coming from a whole nother town, a whole nother city, which is, I'm like an hour and something away from Dr. Halperin office. I pass a lot of other clinics up to get to Dr. Halperin. But it's just what makes it so great about it. I could pass all them up and go to him for everything. I mean, I get everything, my Sebastians, my HIV meds, I mean, everything from him. So it's by being able to just go to this one doctor and get everything done that I need done, I appreciate everything. Everything. It worked out good for me. It's really, really worked out good.
So the key take-home points: rapid initiation of ART is supported by the current guidelines. Ongoing substance use is not a contraindication to initiation of ART. No, just the opposite. We should be starting ART as soon as possible. Patients with HIV and substance use disorder should be offered treatment of the substance use disorder as a part of their HIV care. And that is definite. And if you can co-locate it in the same clinic, that is ideal. And if you can do it yourself, that might even be optimal. There are minimal drug-drug interactions between medications used in the treatment of opiate use disorder and initial ART regimens. Medication treatment for opiate use disorder improves HIV viral suppression. That is the most important take-home point. Our goal is to support our patients and for them to achieve viral suppression. So thank you so much for this opportunity, and please go online for more clinical care options activities on key decisions in HIV care. There are medical minutes and podcasts with expert faculty, clinical thought commentaries from physicians and patients just like mine, patient education sheets to print and share. So thank you again for this opportunity.
Thank you to Dr. Halperin, and thanks to you, the listener. To listen to more episodes in this series and to see slides and webcasts on key decisions in HIV care, see the links in the show notes. Thank you, and have a great day.